experts meet. Online learning, practical and sweet. Every Saturday, 9 a.m. Central Time. YouTube, Facebook, X, and LinkedIn. Online.
Hey, good morning and welcome to Euronurse. I'm your host, Vic Sinise. Hey, I'm glad you're joining me on the 4th of July, our country's 250th birthday. Wow, what a great place to spend it here with Euronurse, learning more urology. I'm glad to see you're here. Hey, everybody, be sure to stay cool because this temperature has been kind of a bugger, man, for some of you folks who don't have good electricity. Like I saw in New York, some places were blacked out, and this heat, it's dangerous. So stay cool. That's my big thing for today. All right. Well, let's get into our show. Hey, by the way, don't forget to like and subscribe. You guys are killing it. We're doing great on this show. We're getting lots of people that are subscribers to our YouTube channel. So we love that. Now, excuse me. In today's program, we're going to be highlighting an outstanding CME CE-accredited on-demand webcast featuring Dr. Charles Bodine, who provides a concise case-based review of the rapidly evolving landscape of bladder cancer care. Boy, has it changed recently. As new therapies continue to transform the treatment of non-muscle invasive, muscle invasive, and metastatic urothelial carcinoma, staying current has never been more important. This educational program explores how recent advances are changing and personalizing treatment decisions across the entire bladder cancer continuum. With practical guidance you can apply in everyday clinical practice. So let's get going. Remember, this will be good for one contact hour, and we'll go over how to get that at the end of the show. So, hey, sit back, enjoy, and learn everything you need to know.
Learning objectives. This is what we're going to cover. We're going to focus briefly on a little bit of epidemiology beforehand, and then we're really going to go through every space a little bit. So we're going to do the non-muscle invasive bladder cancers in terms of localized therapy, in terms of systemic therapy. We're going to go into the muscle invasive bladder cancer localized, and we're also going to take down a little bit of the metastatic disease too. Little bit of epidemiology in terms of what we deal with in bladder cancer. It's not the most common malignancy that we see, but it is quite common. So every year we diagnose about 85,000 cases of bladder cancer in the U.S. that are expected in this past year. The majority of these patients are males. The majority of them are somewhat older, which will present some of the complications for our treatment. The risk factors that we see, mostly across the board, we see smoking. That's the most common one that we see. There certainly are occupational exposures. These things we don't see as much, but we think of aluminums, we think of plastics, we think of artificial dyes. Those are the things that these molecules are in. Certain medications and herbal supplements, a diabetes medicine, pioglitazone. There's an herbal supplement as well, ursodeoxycholic acid, cyclophosphamide with chronic hemorrhagic cystitis can be associated with it, and then just chronic inflammation of the bladder, largely related to chronic urinary catheter use. So this is kind of the picture that we want to focus on and why it's important from a staging standpoint. So this is the threshold where if you only involve the lamina propria, the majority of these patients are going to be managed by urology. As soon as you invade into the muscle, this is where we're going to end up having more problems. And then the deeper you go to involve the tissues around the bladder or other spots, it causes higher risk for recurrence and ultimately ends up with lower overall survival. So even localized settings, if you get into the T4 range, you're probably looking at 10-year overall survival of like 20%. So even localized can be bad, higher risk of recurrence. So very important. In terms of how we see these patients, the majority, 70%, are diagnosed with non-muscle invasive bladder cancer. So in the hematology oncology space, we don't see a lot of these patients. They're managed by urology. But we do see about 20% are muscle invasive and then de novo metastatic disease in about 10%. In terms of what we do for surgical evaluation, the first thing we all see is TURBT. That's the first line for treatment, and it's also diagnostic. So transurethral resection of bladder tumors takes away the tumor, hopefully improves symptoms if they're having some, confirm the diagnosis, and determines how much it involves the muscle. And it gives us risk features in terms of where do we go from here and what are the best treatment options. So we're going to talk first about non-muscle invasive bladder cancer. I don't want to spend a lot of time on this, but there certainly are some roles for medical oncology for our space as well. This is a busy slide that basically says non-muscle invasive bladder cancers are not all created equal. We can see based on low risk, intermediate risk, and high risk what leans you towards certain treatments. And this is very low yield for you guys to memorize, but just gives us an idea on different pathologies. I will do a shout out to the different types of pathology, so the histologies that we see that may actually have higher risk features. So unanimously, we see mostly urothelial carcinomas, but just pay attention to this as they might have a higher risk. So pretty cool slide in terms of how we manage this. Some of the lower risk patients, again, are managed by urology, so we don't see them a lot in our clinics, but sometimes we do. In terms of the intermediate risk, which is what we see a lot, transurethral resection followed by BCG. BCG has been the standard of care for 40 plus years. So, I mean, it's hard to beat BCG, our tuberculosis vaccine, from in the bladder. But certainly not all of our patients are going to respond or tolerate, and eventually some of them will progress to either BCG refractory or to ultimately to metastatic or advanced disease. So we consider high-risk BCG unresponsive patients down here into this little segment where we look at recurrent disease within induction, within 6 months of it, persistent disease within 12 months of adequate BCG, and then if you have persistent disease following the induction, which we need at least generally 2 treatments for that. So the BCG naive patients that we look at, obviously we say do either a BCG with bladder-sparing treatments or a cystectomy. But when we get into this higher risk patients, you're going to see a lot of these things, and a lot of this stuff is actually going to come up in practice coming up soon. And this is where medical oncology may come into play in this. So when you have recurrent disease, intolerance to BCG, then we have to think about other options as well. Pembro was and is approved for the treatment of this. We'll go through the data a little bit. I'm not even going to attempt to try to pronounce these names down here. Ultimately, what those are, like inside the bladder immunotherapies. So one affects interferon, one affects IL-15, basically a localized immune response. So those are important. The gemcitabine intravesicular system is pretty cool and coming down the pipeline. So this is something that we will be seeing a lot of. I'll talk about it a little bit. We call it the pretzel, just based on how it looks. And I'll kind of go through that a little bit too, a little bit later per the TAR 200 trial. So in terms of just kind of superficial view, we know that for BCG being the preferred option, if we have the ability to control the disease and potentially spare them a cystectomy, but early cystectomy can have good responses as well if there's other issues. There's obviously downfalls to BCG. You have recurrent cystoscopies, catheters in place, but obviously we've seen patients, if you have, that have had cystectomies, they can be very hard and it can be quite morbid in terms of kind of the side effects from the surgery as well. So for the very high risk patients, we know that there's a risk of failure. We know there's a risk of progression. So this just kind of gives us an idea. I mentioned the histology that we think of as high risk, if there's involvement of the urethra, and then if there's also a lymphovascular invasion, and that kind of leads us to that. And then again, radical cystectomy is an option. I have a patient right now that's currently going through this that received one of those immunotherapies and BCG and still has disease. So he's currently working through that as we speak. But again, we see that there are definitely side effects, not just the fact that you have an ileal conduit, but also the other features that come around, GI disturbances based on the ileum involvement for surgery, and then other manifestations for this. So I mentioned I'd go through this. These are the 3 things that we look at in terms of localized treatment. Again, I don't want to spend a lot of time on this because we're not going to see a ton. What you will see is that after BCG failure, so if we're still going for intravesicular treatment, these little immunotherapies, the interferon and the IL-15, have pretty significant complete response rates. This is the one that I've seen used as much. I think the brand name is Adstiladrin, but it's one that we can see pretty significant. And the reason why I said Pembro was a thing is that these can still be managed by urology. This requires obviously a second doctor, and there is some overlap that's in here too. Not as good of a complete response rate, but not having catheters and getting medications in that too. So those are things that we need to be familiar with as you see them. TAR 200, so I mentioned this as well. So this is the gemcitabine intravesicular system. I called it the pretzel for a reason. So what this is this is a little small disc that's actually inserted into the bladder, and it's like a sustained release gemcitabine. So you have this disc that you put into the bladder via catheter, and then when it gets into the bladder, it actually transforms into a pretzel-like shape so it can stay in the bladder. And it releases gemcitabine. intravesicularly into this. The trial that we looked at combining this inside the bladder with immunotherapy, citralumab, but monotherapy seems to be the one that's being utilized. So this seems to be potentially something that we're going to see a lot more of. Not sure if they'll take on BCG in this situation down the road, but this is one that the urologists, I think, are going to start seeing more of, and you guys are going to need to be familiar with it as you see these patients come through clinic, especially if we combine them with immunotherapy as well. Most of the side effects, though, are inside the bladder, so you avoid the systemic side effects of immunotherapy, but you also have cystitis, urinary symptoms, and you have to have catheters done. But if you respond, you can actually get to a point where you only have to do this every 3 months for down the road in kind of a stability standpoint. So overall, well tolerated, but highlighting why this is a big deal is that the complete response rate is 82%. So this is coming to a clinic near you, so just be aware of this as well, per the TAR 200 as well. We're going to move on into the muscle invasive space. We had this slide beforehand where we basically say, all right, well, if it doesn't involve the muscle, typically managed by urology. As soon as it gets down to involve the muscle, which is in the T2 space over here, then that's the one where, hey, we know there's a higher risk of recurrence. We know there's a higher risk of metastatic disease. And so ultimately, we end up being involved in the majority of those patients as well, whether it's for neoadjuvant therapy, adjuvant therapy, monitoring. And we're going to talk about a lot of those things here in a little bit. And then we have different grades as well. Obviously, we all know the higher the grade, the worse histology, the worse prognosis as well. But a lot of these things we think about. And then for this, we need to know what is actually resectable disease. So you can have some nodes that can be resectable. Obviously, if you get more nodes, we tend to prefer systemic therapy as opposed to surgery for these patients as well. So not to remember the staging, but just know kind of this is the part that we're going to be talking about now, are these stage 2s and these 3As. So busy slide. I think for us, when we talk about what is the best treatment for these muscle invasive bladder cancers, the standard of care has been and is still radical cystectomy. If we are doing radical cystectomy, then the plan is whether or not it's cisplatin, or if you're platinum eligible or not. So if you're cisplatin eligible or not. And so we also have the option of trimodal therapy, which is removal of the bladder mass as much as you can, followed by concurrent chemo and radiation. And there are some data that says that if your life expectancy is 10 years or less, that these can be equivocal. So something that can spare some of our patients from having a cystectomy and have treatment. And I've got a couple of patients that Caitlin and I see that have had a complete response to trimodal therapy and have been able to keep their bladder for other reasons. I think what leads me to this in this slide is more this corner and this corner, what favors the radical cystectomy. And this is not just straightforward, you're a candidate or not. Lots of things play into it. But if you're having subsequent bladder function, if you have inflammatory bowel disease or previous radiation that may affect the bladder as well, and if you've got diffuse carcinoma in situ or multifocal tumors, then we tend to prefer the cystectomy route if possible. But if they're a higher surgical risk or they just have a desire, which most people have a desire to keep their bladder, then trimodal therapy is favored at this as well. So that's what we look at in terms of this. We talk about what do we favor and when it's not an option, but this is definitely something that should be considered in these patients. This basically just looks at what is the benefit of adding chemotherapy to radiation. We do concurrent for lung, for head and neck, for some of the GYN treatments as well. It's pretty similar. Most of the data seems to support cisplatin alone. That you do this, and you can see that the relapse survival and the overall survival does favor the use of chemoradiation instead of just radiation as well. And you can see those on these Kaplan-Meier curves down here where sorry, I'm pressing the wrong button again. So 63% relapse-free survival for 5 years with the chemo RT arm versus 49% in the radiation arm alone. So there are some other options. Obviously, cisplatin eligibility is something that we'll talk about here in a second, but there are some other options that we can utilize as well. So in terms of this is probably, to me, probably the biggest slide that you can use for what is like a cliff notes for this. So cisplatin eligible versus cisplatin ineligible. So there are guidelines that you guys will see on NCCN or in other things that tell us, well, who's platinum eligible or not. And that really is the quintessential fork in the road for these patients. It's interesting how it actually came about is that they established the guidelines for cisplatin eligibility based on a survey sent to 100 medical oncologists several years ago. I think they got about 50 people to respond, but they liked the answers, and so it ultimately became standard of care. There have been more validations in here, so we're looking at heart failure symptoms, renal function, persistent neuropathy, ototoxicity, and functional status are the things that we look at. It falls on a spectrum here, but that's the fork in the road for us, and you can see why, because the treatment options for these are very different. So for us, when we look at the options, and we're going to dive into this a little bit, but neoadjuvant chemo, if you're platinum eligible, should be the standard of care. And if they're a candidate for cystectomy, you really want to make sure that you kind of lean this, because it does have major implications on the patients in terms of recurrence risk and overall survival. We know that just doing cystectomy alone is not as good as doing neoadjuvant chemo. So there's two chemos that we've used in the past for these regimens. There's dose-dense MVAC, which is 4 drugs in a dose-dense fashion, and then there's GemCis, which we're all familiar with. Most data seems to support dose-dense MVAC's probably a little bit better, but it's a little bit more toxic and has some different side effects that come along with that. It's more neurotoxic, cardiotoxic. It can be harder on the counts as well. But more recently, we have combination perioperative therapy with GemCis Durva. And both of these options are highlighted because they have not compared to each other, so we still don't know what our standard of care should be in these situations, but it at least adds to the conversation with our patients as well. Cisplatin eligible, this was one of the things where we would say go straight to cystectomy. We can do some things where we can split the dose of cisplatin. Do not recommend carboplatin. If I take anything away from this, in the curative intent setting, carboplatin is inferior to cisplatin, so do not use carbo in that situation. But more recently, we've had perioperative EV Pembro that we're going to talk about here in a little bit. We also use this in the metastatic setting based on some pretty impressive data as well. So that's the thing that's there. Coming down the pipeline that we don't know right now is going to be what happens if we use this regimen in the cisplatin eligible space. We know how much it's favored over chemo in the metastatic setting, so we anticipate probably that's something that will come up into this section as well, but not yet. So maybe if I'm invited back next year, we can talk about it then. We talk about adjuvant therapies for this, and this gets a little murky based on whether you get neoadjuvant chemotherapy or chemoimmunotherapy. But we look at these patients and say, well, if they have residual high-risk disease after this, then what is the best option for us? And so we have approvals for, obviously, continuation of Durva GemCis after the treatment if they have it. We also can consider the 2 different approvals as well. So we've got pembrolizumab that was approved, and then we've got nivolumab. Obviously, the dosing can sometimes be easier for this, but we do have a subcutaneous version, which is approved for this as well. Oh, for this guy over here. And then we also have to think about if the patient's got EV Pembro in some of these situations, then do we do chemo? And it gets murky. Also making this a little bit more cloudy in the situation is kind of the evolving role of circulating tumor DNA. I'm not going to spend a ton of time on that, but there are trials looking at circulating tumor DNA guiding adjuvant therapies. So as time progresses, that should come into the limelight for how do we utilize that as well. And then again, I mentioned if you got perioperative chemo IO beforehand, generally continuing the durvalumab for a few more cycles as well. And then if you have cisplatin eligible and you go for surgery, same thing goes. If they're not platinum eligible, they're probably not going to do chemo afterwards, but we can do perioperative EV Pembro, or we can do the adjuvant Pembro and nivolumab as well. So good slide, superficial level on kind of how do we manage these patients with curable bladder cancer. This looks at just some of the specific data related to why we chose these. And so this is the Niagara trial, which basically looked at patients who got neoadjuvant gemcitabine and cisplatin in combination with Durva versus GemCis alone. And these are in the cisplatin eligible patients as well. And what you can see on this Kaplan-Meier curve as well, that at 24 months that you've got an event-free survival that's about 10% higher than it is in the chemo arm alone. And you can see that as these curves march out, as data matures, that they still seem to show some separation in overall survival. So to me, this is kind of probably the standard of care for neoadjuvant right now, but obviously some patients can't tolerate immunotherapy, and then it also makes it difficult to discern what we're going to do in the adjuvant setting as well. So, but this right here, the approval is of this past year, and I think I teased this last year when I spoke that it was not approved, and now it is. So doing durvalumab with GemCis in the muscle-invasive platinum eligible should be strongly considered for this. In terms of the EV Pembro data that I mentioned for you guys in the cisplatin ineligible arm, the data is very impressive. Used to be, again, we would send these patients straight for cystectomy. Well, we can see right here that that's not the best. And we can see that there's significant improvement in doing EV Pembro, and just because somebody can't get cisplatin. And this right here basically looks at doing perioperative treatment, followed by cystectomy, and you can see that over time, as you get out into the 2-year mark for this, that we're looking at pretty significant 75% event-free survival compared to 40%. So that's astronomical difference in these two. And obviously, this right here, the pathologic complete response, we know if they have a PCR, they're going to do better histologically. I don't know where the 8.6% CR and going straight to surgery came from. Maybe the urologist cured 8% of these patients with the TURBT. But overall survival is still maturing, but you can see that it's not reached right now, which is a good problem to have. So really exciting for our patients that are cisplatin ineligible, that we can go and offer them something that can make them live longer. And overall, pretty well tolerated. We're going to talk about side effects here in a little bit. So that's in the cisplatin ineligible arm for muscle invasive. These are some teases in terms of what's coming down the road for what are our options for us. And these are for muscle invasive bladder cancer patients for this, whether it's platinum eligible or not. We kind of tease this as well for platinum eligible. Can we compare neoadjuvant Gem-Cis versus EV Pembro? Again, we can see how impressive the data was for EV Pembro and the non-muscle invasive, so it begs the question, is it going to be? So they'll compare that to the chemo arm. And then we have some others where we're combining PD-L1, CTLA-4s, other things as well, the Volga trial and the Energize trial. So more to come. Obviously, this gets to be a little bit crowded of a space, but ultimately all signs are that we're making significant improvements for our patients and making them live longer with better quality of life. So that's how we manage the muscle invasive bladder cancer patients as well. So again, for me, it's more platinum eligibility is important, and then the cystectomy, what do we choose as the next step? And so right now it's several different options, and then adjuvant, how do we merge that with the neoadjuvant setting? If you got EV Pembro before, would you continue immunotherapy if you didn't have a response? So again, it gets a little bit crowded, but something that we will kind of keep you posted on as time goes on. Biomarker testing. So we look at most of our patients that are getting some degree of molecular testing, whether it's under an NGS panel or not. So when we talk about the treatments for these, what we see here is that targetable mutations are obviously most important. The two most common mutations we see in bladder cancer is TP53 and RB. So that just tells us what we're looking at. But from a targetable mutation standpoint, we're looking at FGFR3, mutations with that medicine that we mentioned here, erdafitinib, and then obviously in HER2, trastuzumab deruxtecan with HER2 positivity, approved in the 2+, 3+ space for these patients as well. When we look at other things, obviously we could find something else on NGS, may depend on the histology that's there. But in terms of PD-L1 testing, we get to do this in the majority of our cancers. The reason why we don't do that single right now is that basically irrespective of PD-L1 is that we're still using immunotherapy in these patients as well. So that's the reason why we're not necessarily recommending direct PD-L1 testing. It tends to come in the group with a lot of these as well, but that's the reason why. So these two, as the targetable mutations, are important. I've seen one PIK3CA as well. I think that's reported in the data as well, but we're not going to focus on that today. So as we go through the first-line systemic therapy for these patients with the metastatic disease, there used to be a lot of conversation about what do we do with these patients? Do we do chemo? Which chemo do we use? There's no conversation anymore. This is our frontline standard of care, first-line metastatic cancer patient for these is EV Pembro, whether you're cisplatin eligible or not. What we can see in terms of other recommendations, yes, there are some people that cannot get immunotherapy. We've all seen the people with poorly controlled autoimmune conditions as well. And so there is a role for chemo, but if they have no contraindications to immunotherapy, myasthenia, bad inflammatory bowel disease, then we're doing EV Pembro. But just think, these are still options, and these are the same options that we had in the neoadjuvant space, Gem-Cis. I will throw out here as well that in the metastatic situation, carboplatin is approved, so you can utilize carboplatin in this situation as well. Just we don't recommend it, and it's not recommended in the curative intent setting. And so I mentioned this. We've also got some, if you put them on Gem-Carbo or Gem-Cis, and then you put them on adjuvant therapy beyond that, if they have stable disease, per the Javelin trial is helpful. We have atezolizumab, which is also approved in some of these situations if they're platinum ineligible. Why is EV Pembro so impressive? So you saw the data in the ineligible patients. This is in the metastatic platinum eligible patients. And this took on the beast. This said EV Pembro versus Gemcis per the EV302. And this was a practice-changing trial for us in terms of what we do. And obviously, you can see the differences in this too. So overall response rates for EV Pembro is through the roof. So we're looking at 67% with a complete response close to 30%. We're looking at 12% complete response in the chemo arm. And then as we go over to the Kaplan-Meier curve and see where we are at the 2-year mark, you can still see that there's a significant overall survival benefit, almost doubled. So there's a reason why we don't think about chemotherapy in that situation. If we don't have to, generally it's safe for the second line. But big deal for us in terms of it. And this is why it's interesting to think about such strong data for EV Pembro in the non-platinum eligible patients, and in the metastatic setting, is it going to be chemo in the platinum eligible? So stay tuned. The side effects that we look at for these, so there is some overlap for these patients as well. So the EV Pembro that we see as well, both of these medications can cause cutaneous manifestations, and they can get a little bit murky in terms of which one's causing which, but it's something that we have to consider for both of these as well. Probably for me, the most common besides the skin rash that I see, which is usually not dose limiting or making you stop treatment, but peripheral neuropathy, real, and it absolutely can be permanent. So you have to pay attention very closely to these patients for peripheral neuropathy events as well. And I've had to probably dose reduce every single patient that I've had so far, if they're on it long enough, for some degree of peripheral neuropathy. Now we can see that there are some ocular disorders that are in here. We can see hyperglycemia. So some people say if your A1C is poorly controlled, that might be a contraindication. We'll call that a relative contraindication for these patients as well. And then I mentioned the motor neuropathy events. And then some of these do have interstitial lung disease as a possible side effect for these patients as well. So in terms of the safety, however, though, as we look at treatment leading to discontinuation, you still have 2/3 of patients that are able to stay on this trial and stay on this regimen for quite some time. So again, I mentioned this as well. And then as we go through immunotherapy, we're not going to perseverate on that. We all see that all the time, knowing any of the adverse events. We think of the lung, we think of the diarrhea and the colitis, we think of the dermatitis, we think of the endocrinopathies that come along with this as well. So stuff that we focus on, and again, can be some overlap with these two, but it's important to distinguish between those as well. I will say that for the mention of the interstitial lung disease that we see, it's not nearly as profound as the trastuzumab deruxtecan as well, but it's still something that we want to pay attention to. So this is also a super cool slide in terms of how do we sequence this as kind of a bird's eye view for knowing these patients that are metastatic in this situation. So we can see that even in the platinum eligible patients, EV Pembro is recommended. If they have some other issues related to inability to tolerate immunotherapy, then that's where you can still consider chemotherapy. In the cisplatin eligible, obviously we're not going to do it, but I mentioned to you as well, carboplatin is something that can be utilized and is recommended and guideline driven in the cisplatin eligible arm as well. But what you can see is that if you get one first, you're going to get the second one afterwards. So these are first and second line in general. No. This is where we talked about some of the targetable mutations as well. So if this one gets chemo and immunotherapy and they can't get EVO, which I think I mentioned that as the hyperglycemia and potentially pre-existing neuropathy is the only things that I think of as reasons why you can't do this, then you go straight into targeted therapy afterwards. And so this is where we mentioned the FGFR3 mutation and then the HER2 positivity for these two medications as well. So erdafitinib is an FGFR3 mutant, and so what this looked at in terms of efficacy is comparing it to chemotherapy, and generally this is after your first lines of chemo, so probably second and third line chemos as well. And you can see that compared to chemotherapy as well, that there is an overall survival. Sorry, I'll figure out the buttons before this is over. The overall survival data, it does favor the erdafitinib arm. Obviously, we're getting into further down the road that the responses are not nearly as robust for this, but certainly it's an option for patients and it's a pill. But as a lot of our pills are, they're not always completely well tolerated, and some might argue that chemo can be better tolerated than this as well. You start with an 8 milligram dose for this medication, and then based on their phosphate levels and based on how they're doing, then you can actually ramp up the dose as well that we'll talk about in a second. That just gives you an idea on why the FGFR3 mutation is checked and why it's approved in this situation. Side effects that we see with erdafitinib. So at the top of this is the one you need to know about, hyperphosphatemia. When I first started, I didn't really think of the side effects that come along with hyperphosphatemia. You're like, oh, it's just a lab abnormality that's there too. But if it gets out of whack, it can cause some serious problems as well. So that's probably the thing that we worry about the most on a day-to-day basis. Then we're looking for GI side effects, stomatitis, hand-foot syndrome. We can see some liver enzyme elevation, some dysgeusia and appetite problems too. I think that, yes, there's not a ton of grade 3 and 4 side effects that come along with these as well, but having stomatitis, having diarrhea, having decreased appetite and fatigue every single day for taking a pill, even the grade 1 and the grade 2s can be very relevant for our patients as well. So those are the side effects that we see with this. You can see that to some extent, pretty much everybody's going to have some side effect. And at some point, you're going to end up having some grade 3 or grade 4 down the road as well. And most of them will have to discontinue if they not for progression of disease for side effects. So the ones that we mentioned as well, we can see some skin disorders. Retinopathy is a very real thing as well, and these patients are generally following with ophthalmology. And then I mentioned the phosphorus as well, which is important for us to know. Going through the Destiny PAN-02, which is trastuzumab deruxtecan, we can see that this has got tumor agnostic approval in a lot of our treatments if it's high enough. We can see that for HER2 3+ and 2+, that it's approved in this situation. Responses are going to be a lot more robust in the higher the HER2, which makes sense. And this is just basically saying, do we have this? Now, we have to take it somewhat with a grain of salt, obviously, with only 41 patients in the bladder cohort that were here, but you can see the waterfall plot with these patients, like very responsive, very durable, and pretty impressive results in terms of the tumor reduction for this as well. The overall survival for this being somewhere in the 13-month as well. And then we've used this a lot more in the breast setting and some others as well, but we're all got to be familiar with the Q3 week dosing based on certain things, and then managing the side effects that come along with that, which you'll see here. So more commonly, you'll see the GI side effects, the low blood counts that come along with this, and you can see some alopecia that comes along with this. And then I think the main thing takeaway for us is 10.5% will have ILD pneumonitis, and that varies from asymptomatic to very symptomatic as well. So we oftentimes will get more frequent scans of their chest to make sure that there's not developing some pneumonitis with this. So I think for us on a day-to-day basis, we want to make sure that we understand, like, yes, we know what to look for, we know why we pick certain medications, but how do we manage the day-to-day side effects for our patients that are on these medicines, dose reductions, and supportive management as we go through this as well. So as we go through the approach to all of our patients as well, I think just being familiar with the medications that we're going through right now, why we use them, what are the side effects, how do they work the way that they do. I didn't even mention that EV's mechanism of action we didn't talk about is a Nectin-4 blocker, so it's novel compared to chemotherapy as well. But understanding what are these unique adverse events that we see in this field compared to traditional chemotherapies, what regimens may complicate the adverse management due to overlapping toxicities, and then teams working together as well, whether it's urology, whether it's endocrinology, whether it's neurology, depending on side effects that come through, and then specifically to these medicines, probably more ophthalmology and pulmonary for the ocular toxicities and pulmonary dysfunction as well. And then obviously knowing, like, well, what other things are we seeing in these situations? And obviously for our consultants, like, they may not be as familiar with some of these medications as well. So we're probably going to see more dermatitis from immunotherapy and EV than the dermatologists are. But obviously a multidisciplinary approach is always important for us too, when you don't have a clear diagnosis for these. So going through EV and some of the medicines, we've talked about this. This is a picture of kind of what we expect to see with these. We see that for both of these medications that we see, that we do see a good bit of alopecia. So just be aware of that. But enfortumab side effects, and then as we go through the trastuzumab deruxtecan, the GI side effects and the interstitial lung disease. These are kind of the onset of symptoms that we tend to see with EV Pembro. This medicine works pretty quickly. We can see people with responses within as short as two months. So you actually can see responses at the first scan for these. But where do we see these patients? And so we can see the hyperglycemia tends to onset a little bit earlier than what we're used to dealing with immunotherapy side effects. The dermatitis that comes along with the EV Pembro, generally we see that somewhere in the 2 to 3 range cycle. Again, you can see the range of this is very broad, so take that with a grain of salt. But then further down the road with cumulative exposure to these medicines and cumulative exposure to the accumulating side effects, we see after cycle 6, cycle 7, that's when we start to see the grade 2 peripheral neuropathies, the more symptomatic or radiographic pneumonitis that we see as well that are a little bit further down the road. Not typically going to happen with the first couple of treatments. So in terms of hyperglycemia, we know it can be severe even in patients without diabetes. The diabetes makes it a little bit more difficult for us to manage, especially if their A1C is above 8. So we don't want to have complications from that if that gets worse. So our ultimate goal from a hyperglycemia standpoint with EV is basically lifestyle modifications, primary care discussions, and potentially on medications for these as well, and then also making sure that they have the supplies and resources to check their blood sugars as well, because we all have patients that they don't check their blood sugars. There's no way they could be high, but in fact they actually are. So educating our patients and the caregivers about the risks that come along and then the symptoms that come along with severe hyperglycemia. Throw back to our internal medicine stuff where we see polyuria, we see polydipsia, you see blurred vision, confusion, GI symptoms that happen. Generally with time, we can see the kidney and ocular side of things that come along as well. So assessing an A1C and then monitoring it throughout the course can be helpful for us. And in terms of the management, most of the time it's discussion with the patients. Knock on wood, I have not had any people that have had to discontinue for hyperglycemia. I think the point is, okay, if you have metastatic bladder cancer and you have hyperglycemia, which one is more important for us? But we also don't want to ignore the side effects of untreated, unmonitored hyperglycemia. So considering referral to endocrinology, talking about medications for these patients, and then also like what other things do we see that can affect the blood sugars as well, which a lot of times in our field, we've got people on corticosteroids. In terms of the modifications, though, we can hold it if the blood sugars are above 250. So if they can't get a PET, they can't get EV. We resume it at the same dose once we control it, so you can do them simultaneously. And in terms of DKA, you hold it and urgently consult endocrinology, and if they come out of that, you can still re-challenge them. That one I've never seen, but something to keep in mind. In terms of the dermatitis that we see with these, so we can see that there's several different types of rashes. And it's not across the board. You're going to see the same rash. You're not going to know the extent of where the body surface area is, but you can see that on the grading, it is important for the body surface area on what is actually being utilized. For most of these patients, though, as we go through this, you have to educate them and know that, yes, it's usually controllable, but there are some very severe complications, which is Stevens-Johnson syndrome or toxic epidermal necrolysis. So being aware of that is important. Lifestyle changes historically are pretty well tolerated and are able to keep people on treatment. So skin barrier, sunscreen, proper hydration as well, cleansers as well. And then as we look through the assessment to monitoring their rash to see if it's getting worse, getting better, or if it's from other reasons as well. I would say the majority of these patients, especially in the grade 2 and below, very responsive to topical corticosteroids and antihistamines. But we can see that obviously as they get better or get worse, which falls into the Stevens-Johnson syndrome and the TENs, these are grade 3 and grade 4, and these actually justify permanent discontinuation of this too. So being aware of where it is based on severity, and then whether or not how severe it is, you actually need to decrease the dose. The ocular side effects, we talked about needing an ophthalmologist to go through these as well. So we want to make sure that we can prevent these with good hygiene, with artificial teardrops at times. That's a preventative measure. It doesn't mean that that's the treatment of the side effects from the EV. But we want to educate them as well, and oftentimes have baseline and intermittent eye exams. If we want to monitor for the symptoms, you got it. If you don't ask, you may not know about it. And patients might not realize that that's an option for us. And that's, again, going to be on EVO or EV, and we'll talk about it with the FGFR treatments as well. But for dry eyes, you can use artificial tears for actual involvement of the conjunctiva. Warm compresses can help. But for these, we do consider dose interruptions or reductions. However, in terms of the severity, that's important for us. So grade 2 corneal adverse events, and this goes along with the dermatitis as well. If it's grade 2 and below, you can hold until it's better, and then you can actually resume at the same dose. If it's grade 3 or higher, you're typically going to dose reduce as well. So can continue at the same dose. Not everybody recurs, but something that we have to watch for as well. The peripheral neuropathy, I mentioned this, and this is the thing that I probably see the most and is the most debilitating for our patients. If you're on this medicine long enough, you're going to develop neuropathy. And so when we see these patients, we need to make sure that we're telling them about it, knowing it's a very real thing, monitoring if it gets worse, and making sure that we make the appropriate adjustments from a peripheral neuropathy standpoint. So we consider physical therapy, we consider the medicines, similar to all of our patients that get taxanes and platinums and other things too. These are our options for medications. We all know they don't always work across the board, so thinking about other options. And then again, if there's, most of the time it's pain or numbness, but if they have actual sensation impairment, then obviously making sure that they don't have injuries that they can't feel, similar to our diabetic patients. And then similar to the other ones for side effects, if it's a grade 2 or below, which is somewhat subjective, then you can actually hold it and then resume back at the same dose. If it recurs again, generally you will lower the dose as well. So that just helps you in terms of what it is. You don't have to drop the dose at first. If it's severe though, grade 3, severely limiting your ADLs, then that's something that you need to consider permanent discontinuation for. So this just gives you the grade, and again, I told you it's subjective, it is. So you're not going to be able to just say, put it into a thing and say, all right, we're 2 versus grade 3. But I mean, we've seen enough of these patients to know if they're limiting some instrumental ADLs, we think of it as 2. If it affects your ability to take care of yourself at home, then that's grade 3, and that can be more debilitating as well. Life-threatening consequences, I have not seen, but generally when we get in that grade 3, grade 4 range, if they have superimposed infections, things like that, then we have to consider permanent discontinuation of these as well. Interstitial lung disease, pneumonitis with these as well. I've never used the 5S rule, so I don't really know what it is, but for the sake of this presentation, you will screen your patient, you will scan your patient, you will synergize with your patient, you may suspend with your patient, and if you need it, you will steroid your patient. I'm going through the incidence of this as well. So we know that from the pneumonitis, I mentioned somewhere in the 10 to 11%. I've seen it from severely symptomatic to completely asymptomatic and radiographic. And it's shared decision-making. I mean, we say you have to discontinue this, but if you have a patient who's responding and has asymptomatic inflammation on their lungs, that's got normal oxygen saturations and no symptoms, are you going to discontinue a good drug because of that? Probably not. But we still have guidelines that come along with this. And in terms of the medications, because we're combining these medicines, we have to think about the incidence as well. So grade 3 is significantly lower in the EV Pembro arm compared to the TDXD arm, so be aware of that. And there's package inserts that will tell us that, hey, if it's there and it's severe, you have to discontinue your treatment. So if it's grade 2 and above, then you will discontinue the drug permanently. If EV Pembro, generally if it's grade 3 and above, or if you have recurrent grade 2 disease, then you will discontinue those as well. So we mentioned overlapping toxicities that fall along with this. We have to be aware of the pulmonary side effects of these medications and know how to manage them as well, and make sure that we don't re-challenge them and make things worse. Corticosteroids and pulmonary referral, generally the situation for both of these as well. Obviously we've seen pneumonitis that has responded beautifully to this. I have not seen steroids as much used for this, but generally it's probably because I'm more aware of it and monitoring it closely with your 5S rules with our patients so that we can make sure that if we do find something developing that we can discontinue in appropriate timing. So we will follow all interstitial lung disease events until resolution after discontinuation. So this is the grades, and again, this falls along with checkpoint toxicity as well as the trastuzumab treatment and the pneumonitis that comes along, and technically the pneumonitis with EV, which is less common. Again, asymptomatic, grade 1, intervention typically not indicated. Symptomatic, mildly, then we talk about whether or not it's limiting theirs mildly, or if they start to develop severe symptoms, which again is becoming grade 3, and then grade 4 is going to be hospital patients, ventilator, oxygen needs, those things as well. We try to avoid grade 5 toxicities as much as possible. So managing the nausea and vomiting that comes along with TDXD, it has more GI symptoms that come along with this medication than probably the other medicines that we've talked about before this. And it's moderate to highly emetogenic, and this is real. So we have to make sure that we're on prophylactic regimens for this and making sure we're proactive with the management of this as well. So we're talking generally double to triple therapy as well, 5-HT3s, NK1s, steroids that are done. Most of these patients I've got on olanzapine as well. So trying to do that before, and then obviously managing their symptoms beyond this as well. These are pretty similar to some of our other chemos as well for delayed onset nausea and other options as well. But just be aware, yes, it's not a chemo. Yes, it still has very real side effects. And yes, we have to be proactive at trying to prevent those. For the grade 3, grade 4, or grade 3 nausea and vomiting that we deal with, you can delay the dose until it's grade 1. If it resolves quickly, you maintain. If it does not resolve quickly, takes time, then you typically drop the dose of this as well. Erdafitinib, we talked about this a little bit in terms of side effects. Ocular is probably more prominent. Hand-foot syndrome can be very real, nail toxicities, and then the hyperphosphatemia, which I told you was something I thought was asymptomatic and was irrelevant until I did more research, and these are the symptoms that can ensue from this. So it's something that's very important because it will affect your management in these patients as you're seeing in follow-up. So it can cause ocular issues. It can cause cardiovascular compromise if it's really bad. Probably for us, more altered mental status is the things that we see, and it can have neurologic symptoms for comas and seizures. Muscle cramping and tetany that we can see. The symptoms that we see for neuromuscular side effects with hypocalcemia, we see with hyperphosphatemia, and then paresthesias are something that we can think about as well. And why that's important is because it falls on a spectrum of where your phosphorus levels are. So these patients are typically monitoring phosphorus. I mentioned we start with a lower dose and based on the phosphorus can go up on the dose, but this will tell you as you're going through this, what do we need to do during treatment? So based on the levels, we continue erdafitinib. We'll start a phos binder in clinic if it's above 7, and then we can reduce the dose if it does not come down. If it stays up, then you have to dose reduce, but you can actually continue if you can control it with a phos binder. As you get up into the 9+ range, that's when we're having to hold the medications that are here as well. And then in terms of how do we tolerate this, we're holding it significantly for double digits, but knowing how do we consult patients on this or counsel them, it's not just a phos binder. How do we avoid those in nutrition, which is phosphate foods, milk, cheese, grains, dried peas, nuts, seeds, and chocolate. And so just being aware that there are guidelines that come along with that. Hand-foot syndrome, I'm going to speed through this because I'm running out of time, but basically looking at what are these as well. This is basically the same thing that I typically think of with our capecitabine patients that are on too, that we see them. So making sure that we're doing thick moisturizing creams or lotions and using agents like urea cream and then cortisone creams if it gets bad, superimposed infections, antibiotics, and if it gets to be grade 3, we hold it. And so that's the hand-foot syndrome that comes along with it. Nail side effects, I'm going to push through just for the sake of time. Y'all can check this on the deck as well. And then the ocular toxicities, they really fall into the importance of making sure that you have a good relationship with your ophthalmologist as well. Having baseline and knowing changes that come along with it can really help us to know what they are. I don't know about y'all, but if somebody asks me about central serous retinopathy, I'm not going to know what that is. So I need a good relationship with my ophthalmologist. We certainly don't want a retinal detachment in these patients. And you're getting exams pretty much within the first 4 months of treatment. I like to have a baseline beforehand and then intermittently throughout that. And then for dry eyes, we use artificial tears, but for something that's severe, then we have to hold these medicines. So if it improves within 14 days, you resume at the current dose. If it's not improving within 14 days, you hold until improvement and then lower the dose for this as well. And then if it gets to be severe or persistent, then you have to sometimes consider permanent discontinuation of this. Key takeaways I'm going to leave here as well. Thanks for having me.
All right. Well, I think that was a great review of bladder cancer. Things have really changed. You know, I've been involved in this field for over 40 years. When I started, you know, we had surgery. That was the main thing. Did a lot more radical cystectomies in the old days. You know, the very first drug that we were using in the bladder was something called thiotepa. Didn't work very well. It was, you know, kind of a hazardous thing to deal with. Patients, you had to always monitor their blood counts because it could cause that to lower. And then came BCG, and I was actually involved with that before it became FDA approved. And I mean, that was the drug that really, you know, knocked my socks off at how well it worked, how much we could prevent going into having to do further surgeries and recurrent, you know, going in there for these tiny little bladder tumors that came back. So, but now, I mean, wow, the checkpoint inhibitors and these chemos. If any of you out there are using any of these products, put it in the comments. I'd be interested if anybody wanted to speak on the pretzel, the gemcitabine pretzel. That's kind of a interesting topic. I've been looking for someone to talk about. So I'm always looking for speakers. I think bladder cancer has come along. I mean, you can see the dates on some of these drugs were just recently approved. You know, Pembro or Keytruda is like used for everything now. It's been one of these checkpoint inhibitors that's really had a lot of success. The biomarkers now in cancer, bladder cancer, again, we didn't know there were biomarkers or didn't know of them or checked for those in years ago, but now you've got some guidance on how you treat everything. So much more pinpoint. So anyway, I hope you enjoyed this. Hey, remember that you can go to the website and you'll be able to see that little box that'll say the 1 credit. You just click that. Now, right now it's on the main section. So if you get there right away, you'll be able to go over and take it. But if you wait, it'll be in the lower section, but it'll still be there. It'll just be smaller, and you just click on it. And that'll get you right to what you need to get your 1 CE for taking the listening to this talk. It's been really great that the company My CME has allowed us to collaborate with them and present their stuff on our show, because there've really been some, really good topics that, again, that you may not also get. Plus, if you need CEs for your qualification to keep up your certification, or if it's time to renew your license, like my license is in Illinois, you have to have a certain number to renew your license. Hey, free is always good. So tune in again every week. Enjoy your 4th of July. And here's what's coming up next week.
In this episode of Your Own Nurse, host Vic Sinise sits down with Eric Kolb, co-founder of Alida, to discuss an exciting new development in the management of post-prostatectomy incontinence. Post-prostate incontinence remains one of the most challenging quality of life issues following prostate surgery. Many patients struggle with stress urinary incontinence, pelvic floor weakness, and long-term leakage that significantly impacts daily living, confidence, and social engagement. Eric Kolb explains how Alida's innovative approach to pelvic floor muscle stimulation is evolving beyond its original applications and being explored for male urinary incontinence support following prostate procedures. Join us on June 20th at 9 a.m. Central Time to learn more.
Yeah, so join us next week to learn more on that June 20th. I apologize for that date. That's not right. It's next week. Originally, he was going to be on at June 20th, but we had to reschedule due to some booking issues. If the name Kolb sounds familiar, we've had Gloria Kolb on, the founder of Alida for females. So that's her husband who's going to be joining us, Eric, and he's working on the post-prostatectomy side, or a male device that's being used to treat the same way. One of the things I really love about this field of urology is there's just so many new devices coming up. It's just keeping up with it is sometimes a big task, but if you tune in the Euro Nurse, you'll find out plenty about it. So, hey, enjoy your 4th of July. Careful with the fireworks. We don't want to have anybody to, it's hard to put a catheter in if you don't have all 5 of your digits. So keep that in mind. But enjoy your day. It's supposed to be a beautiful day. We got a little rain maybe in the forecast, but I think the heat's finally going to start breaking a little bit. So we'll see everybody next week.
So here's to the mornings, the coffee, the monitor glow, to the wisdom he shares and the folks that he knows. Saturday is special when Vic's on the stream with 40 years of knowledge and a head full of dreams.